It is just a huge honor for me to be podcast interviewing Dr. Omid Termechi all the way from Long Island and Dr. Cory Glenn all the way from the beautiful metropolis of Winchester, Tennessee. How are you guys doing?
Doing great, man. How are you?
Well, I want to tell you that this is such an honor for me that I'm podcast interviewing you in the middle of the Arizona Cardinals, my life passion as they're playing the Tennessee Titans. So, Cory, how come you from Tennessee and me from Phoenix? How the hell did we schedule this podcast in the middle of the damn game?
Yeah, I have no idea. Right in prime time for deer season, too. I don't know what we were quite thinking.
Well, so Omid is a leading practitioner, educator, innovator in implant dentistry with offices in Astoria and Long Island. He provides the full range of general, implant, and cosmetic dentistry services. Both offices are equipped with state-of-the-art dental chairs and technology such as low-radiation x-rays and 3D CT scanners. Using minimally invasive, pain-free procedures, Dr. Termechi restores smiles and works closely with his patients to help them maintain their dental health. He received his D.D.S. from New York University College of Dentistry. Now, is that NYU?
Correct.
Yeah, yes. 7% of all the practicing dentists in America graduated from NYU. That is a huge monster school. He completed General Practice Residency programs at the Interfaith Medical Center and at the Kingsbrook Jewish Medical Center, both in Brooklyn. He also completed a 2-year full-time fellowship in Oral Implantology and Biomaterials at the Brookdale Hospital Medical Center in Brooklyn. Dr. Termechi is an attending at the Brookdale Hospital Medical Center, Department of Oral Implantology and Biomaterials. He is an assistant professor at the Implant Department at NYU College of Dentistry. He was an ADA Cell Seminar Series lecturer from 2005 to 2015. He has achieved an associate fellowship status at the American Academy of Implant Dentistry, as well as fellowship and diplomat status in the International Congress of Oral Implantology. In 2017, he founded the Dental Implant Surgical Center, otherwise known as D.D.S, D-I-S-S, Dental Implant Surgical Center, in partnership with Universidad Francisco Marroquin UFM School of Dentistry in Guatemala. This helps general dentists and restorative dentists expand their private practice into implant dentistry. Cory Glenn, who I assume needs zero introduction since he has the most views of anyone. We put up 400 online CE courses. You're always our most viewed. You're always our most popular. He graduated from the University of Tennessee Health Science Center College of Dentistry. Following graduation, he completed the Lutheran Medical Center's advanced program in general dentistry at the UT Memphis branch. He is a graduate of the Georgia Maxi course in implant dentistry, the American Orthodontic Society's comprehensive ortho program, and is credentialed as an associate fellow in the American Academy of Implant Dentistry. He has served as a CE director for the Tennessee AGD and is president and CE director of the Middle Tennessee Dental Study Club. Dr. Glenn is also one of the founders of Blue Sky Bio Academy, the online learning center. For several years, Dr. Glenn ran a private practice in Winchester, Tennessee, where he performed all disciplines of dentistry with a particular focus on utilizing technology and innovative techniques to provide treatment in an efficient and cost-effective manner. Dr. Glenn is the vice president of technology for Blue Sky Bio, the leading innovator of implant technology, where he focuses on product and software development as well as clinical customer support. He speaks extensively about CAD/CAM, cone beam technology, guided dental implants, dental photography, digital smile, complete dentures, and complex full mouth rehabilitation. But Cory, I know my homies. I've been on Dental Town 4 or 5 hours a day since 1998. And do you know why you're so loved on Dental Town?
Why is that? My good looks?
Well, you're good looking and handsome, no doubt about it. But it's the fact that I remember when I got out of school, and it seems like the whole lecture circuit was focused on lifestyles of the rich and famous, dentistry, on elite rich people, models, Beverly Hills. I remember going to the Pankey Institute, just young kids straight out of school. I went through all 5 weeks, but I didn't like it. I mean, I went there, and the first thing he does is starts talking about the A patient, the B patient, the C. And when he starts explaining the C, D, and F patients, that was the entire Farran family tree. And what I love about you is that everybody needs a dentist, and you always keep one eye on the patient, one eye on cost, and you use your God-given talent to drive down costs so your patient can afford to have treatment. And, when I go to a CE lecture, I don't give a shit about how you treat movie stars with $50,000 cases, because that ain't my world. You know what I mean? I'm across the street from the Guadalupe Indian Reservation that has 5,000 legal citizens and 10,000 illegal citizens, and they're pushing weed eaters and lawnmowers and hammer nails for $20 an hour cash, and you always, I mean, you could squeeze a quarter out of a lemon. I mean, how do you do it? You don't you agree with what I just said?
Yeah, that's kind of been born out of just the situation I practice in, because I love doing all that fancy stuff you mentioned, but no one could afford it. And so it's, I just figured out if I was going to do that stuff, I had to figure out a way to do it cost effectively. So I almost get as much enjoyment out of figuring out those ways as I do the actual treatment itself.
And it's the same thing with PPO dentistry. I mean, when I got out of school, Delta paid me. I submitted my fee to Delta. It was $1,000. They paid half. Now they submit me the fee, and it's $600. So all that means is you got to go 40% faster. You still see these dentists my age that their whole career they schedule an hour and a half for a crown. It's like, dude, does it really take an hour and a half? I mean, they'll go numb, and then they'll go sit in their office. And then they'll come back and prep. Then they'll leave, and they'll have their assistant spend 15 minutes behind cord. Then they'll go back and impress. Then they'll leave. Then she'll take 30 minutes to do a temporary. Then you go across, and his overhead is 65, 70%. Then you go across the street, guy will schedule a half hour. He'll go in there and numb, and then he'll set it with Septicane. He'll set a timer 4 minutes, and then he'll take the shade, do the lab script, 4 minutes, ding. He'll pack the 1 cord, the 0 cord, the 1 cord. Then he'll prep. Then he'll make the temporary with his assistant. And that's a great way to check your margins, your occlusion, your clearance, so you don't get a reduction opening. Then he'll take that off, take an impression, go do a hygiene check, come back, check the impression, cement the temporary, boom, 30 minutes. 30 minutes. I mean, so if you're doing a $600 PPO crown and you can do 3 of them in an hour and a half, that's $612. That's $1,800. So I just love the way your mind works. Your mind, you always increase quality while reducing costs. That's the only thing everybody associates with Cory. Just faster, easier, higher quality, lower cost. So what's got you guys passionate today? Tell me about D.D.S.
So this is a program that I felt and I was very passionate about creating. And the way it actually came about was I teach in NYU 1 day a week on Wednesdays in the Peri and Implant department. And one of my old students who graduated from the program 4 years ago, we basically teach international students in NYU, and we have 16 international students per year, and we have 2-year program that they come from different countries, and they spend 2 years learning simply dental implant surgery, and everything that goes with it. So I've been part of that since 2006, and during which I met a lot of people who are, foreigners from different countries. They come here for 2 years, they spend time, and then some of them, they actually go and they, become specialists in perio or pros or whatnot in NYU. But one of my old students who graduated 5 years ago, he's from Guatemala, and they have a fantastic, beautiful, high-end, great technology, state-of-the-art university over there, Francisco American, and he is now the director of the implant program in that university. It's basically a dental school. They provide all types of services, dentistry to the population over there. And I just happened to...
Is it in the capital?
Yes, this is in Guatemala City, which is the capital of Guatemala. I have been going there for the past 2 summers. One of the things that the university does, they basically want to attract more students from Central America and South America to their university. And one of the programs that they did, annually, they do have one meeting that all the Central and South America countries get together. And they did a live broadcast of a different surgery the past 2 years. I did a sinus graft and an immediate implant placement the first year. And then I did the autogenous block graft using the ramus to put on the anterior in the premaxillary area. And that was live broadcasted. So after this 2 events that I went back to back 2 summers, I see that there is a great potential over there. The facility is fantastic. They have room. They teach over there, so it was kind of no-brainer. I decided that it's not a bad idea to create another program where you could basically teach general practitioners. Basically, I came up with an idea of possibly creating a program that we can teach practitioners who don't have any dental implant surgical training to be able to go ahead and learn how to do implants on a basic level, to be able to recognize the patient, to have the tool, to give them the tool that they can recognize the patient and be able to go ahead and perform 1, 2, 3 implants, maybe overdenture cases and whatnot, so they can go ahead and get familiar with it. Because I was just reading an article from AID and that was published in 2006. There's back in 2006, 5.5 million implants were placed in the United States, and 3.2 million of it was placed by general practitioner. So now that the general practitioner
say those numbers again.
5.5 million implants were placed in 2006 in the United States, and 3.1 point something of it was placed by a general practitioner. Not that general practitioners are obviously placing more implant than specialists, but there are certainly more general practitioners. So therefore,
did
naturally,
they break out the oral surgeons and the periodontist, or just lump them under specialists?
No. That number just includes the general practitioners who place implants in the United States.
If you got a source on that, can you email that to me, howard@dentaltown.com?
Absolutely.
Okay.
Absolutely. So that's basically it. We and our program is, obviously we included Cory in this because I recognize that technology is extremely important to people. We want to give them the tool that they can actually be comfortable to place the implant properly. We want to teach them a correct placement versus somebody who takes, let's say, just a over weekend course and didactically they learn about the implant and they have some surgical skills and they want to go ahead and do it. We want to take him from that level of really don't know anything, and then in 4-day period to be able to go ahead and learn didactic and give him the computer guided surgery advancement and teach them that. And for them to be able to go ahead and place the implant just like a pro does. Because once you are able to go ahead and plant it and be able to take it out of the computer and put it on the cast and the model and naturally on the patient, then, patient, they're going to be able to do a good job.
So, Cory, what's your part in all this?
Yeah, so there's really three reasons that I'm involved with this. First of all, I'm working for Blue Sky Bio now. One of the things that we lack, we're a lean company, so we do everything web-based. That's how we keep our costs down. And one of the places we've been lacking is in live surgical training. So historically, we've been a company that, if you needed a rep to come in and hold your hand and help you to pick parts and all that, we weren't your company, right? We were good once you knew what you were doing, but we've been lacking in that respect. So I wanted us to be able to have something where we could take a dentist that knows absolutely nothing about implants and get them surgically competent to place and do it all under our umbrella. And so that's the first thing. We didn't have many clinical courses like that, and the DISS group is providing that, where they can take a general dentist from zero to competently placing through that 4 days. Secondly, if I was going to be part of that, there was a couple of things I wanted it to do. One, I didn't want it to be a deal where, you go to one of these courses out of the country and they slam home a bunch of implants. You have no idea if they integrate. Half the country's walking around with unrestored implants because they're just human guinea pigs. That's always rubbed me a little bit the wrong way, and I know there's some hands-on out-of-the-country surgical courses that way. So I like the aspect of this one that it's in a university setting. The patients are getting followed up. They're getting restored and getting restored at a really high level. And then the other aspect, obviously, I'm a big technology guy. I really feel like guided is the way to do it. Not that you can't do it well without guided surgery, but why would you want to? It makes things, for me at least, so much more predictable. And being able to do all of our surgeries through this course guided and help the attendees grasp that, I think it lowers the risk on the people starting out with their placement. And I think they get a better overall result. And so if I'm starting out, I want to learn it that way from the very start. and not have to go through this really steep learning curve, a freehand surgery where, the first 2 years you screw up every implant that's not on your dominant side, like I did. I just think guided is going to make that so much more efficient. So all of those things matched up with what Omid's talking about, and he contacted me, and I was glad to jump on board with it.
So basically, I know you have a friend in Guatemala and all that, but basically you want to go to Guatemala just to lawyers, because if someone came from Arizona to New York City, they wouldn't be legally hands-on. So is that correct? Is that why you're going out of the country?
So, of course, that's definitely is the case. And the question really becomes, where in the country are you going to be able to find that you could go ahead and take 10 people and find 150 implants that you could go ahead and place, and people are willing to go ahead and come in because you're giving them a fantastic price. Because plus, I have to say that people over there do pay. The only thing they don't pay is the surgical aspect of it. They do pay the university for restorative aspect of it. We have 5 restorative residents. There are 5 cross residents in the university that they're going to go ahead and restore these implants. Now, one of the things that we also, give to our participants is a full credit of our course towards a fellowship of the ICOI. Now, I want the residents to be able to be in contact with any of the participants that we have, and for them to be able to go ahead and see their follow-up cases to be completed once it's completed. If they stay in touch with the resident, they'll be able to go ahead and see the x-ray when it's finalized, when it's finished, when it's in the patient's mouth, so they can go ahead and do that. The other thing is that university takes full credit of possibly any failures that can come from this. They are there to go ahead and secure those failures and to be able to go ahead and replace those failures. We don't want our patients to be a guinea pig. And one of my first slides for the course is to be respectful to the patients and treat it just like you are in your own practice. So we don't want anything as far as patients walking around without with our implants in their mouth and not being restored. We want to be able to go ahead and finalize all the cases and be able to teach our participants proper implant placement. And that's really our goal. And people in Guatemala are paying for a restorative part of it. So they're basically getting 50% discount on the university price on any implant from beginning to the end.
So have you guys both been down there yet to the dental school?
So I've been down there. Cory has joined us after I decided, because this is new, the ISS. This is my new thought and my new creation. And Cory hasn't been there, but our next meeting where Cory is going to be there is going to be on February 19th, 22nd. And that's when we're there, when everybody's freezing here in the United States. At least
God. You got to get me a free speaking gig at the dental school to their students. I love Guatemala. I mean, gosh darn, that country touches Mexico, Belize, both oceans, Atlantic and Pacific, Honduras, El Salvador. I mean, Cory, I swear, if you go there from Winchester, Tennessee, and you go down there and hang out in Guatemala for 4 days, you're probably going to apply for citizenship. I mean, there is no way in the world you won't fall in love with Guatemala City.
I'm actually flying right there from your other favorite place, Sydney, Australia.
Oh, that's where my brother lives.
Yeah, I'll be in Sydney teaching, and then I'm flying straight to Guatemala for that course. So that's going to be a jam-packed.
Oh my! So what's your flight? Sydney to LA, then Guatemala City?
I have no idea. It's all over the place.
My God, that's people don't respect how grueling speakers do. I mean, like when I lecture in India, it's 5 hours in New York, 15 to New Delhi, lecture to 250, turn around and go back home. Sydney, 1 hour to LA, 16 hours to Sydney, lecture, turn around, and oh my God, I feel like I've been a plane rat. Remember that? Oh my gosh, that's just brutal. I'm already hurting for you, and you're having back problems. So hopefully,
I do. Yeah, I have to take a lot of medicine to get through those flights. So that's kind of rough. But I have. It's not a bad deal once you get there. So I'll suck it up.
Yeah. Well, man, Guatemala City. That is. I just love that place. So let's Let's start with day one. When I always ask my homies, and do this if you're listening, shoot me an email, howard@dentaltown.com. Tell me who you are, how old you are, what's going on, who you want to have on the show. 25% of them are still in dental school, and the other 75% are 30 and under. So they're coming out of school. This is what I want to lay on. They're coming out of school, and they all say the same thing. I graduated $250,000 in debt. I didn't place one implant. So you're speaking to her very clearly. Someone that doesn't know anything about implants. Go from 0 to 1 in 400, and in 4 days in Guatemala City. But she tells me all the time that she almost feels like she has to pick the implant first because most of the training available to her is implant company sponsored. So would you recommend that she start with Blue Sky Implants?
So I'll answer, and if Cory wants to jump in. So one of the things I can tell you, we have sponsorship from Blue Sky Bio, but I personally have placed Blue Sky Bio many years now. The beauty of the Blue Sky Bio, one thing I have to say, is the fact that if I am a Zimmer user, I can use Blue Sky Bio. If I'm a Straumann user, I can use Blue Sky Bio. If I'm an Astro user, if I'm a Nobel user, I can use the Blue Sky Bio. So, you have, it doesn't matter what type of an implant you prefer in your practice or you like to go ahead and place. And the reality, one of the things that I suggest is when you are deciding on an implant in your practice, there are certain criteria that has to go with that. One of the top criteria that I have for general practitioners who want to get involved in implant dentistry is to place an implant that is easily restorable. It's economical, sound, and easily restorable. If you want to go ahead and place an implant, that's an implant you should go ahead and bring to your practice. So that's what I would say. You're right. It's a Blue Sky Bio, sponsor implant, but Blue Sky Bio give you, very versatile, different type of implant system that you are able to go ahead and do either hex stop or internal hex or Morse table or, whatever type you want, they're able to go ahead and actually provide that to you. But we are not there to go ahead and say only Blue Sky Bio. There are some people who are coming in that already have implants in their practice, that are already placing implants. We're not trying to go ahead and tell them to change. They're going to place it at Blue Sky Bio implants in our program, and then they can decide on their own if they want to go ahead and stay with Blue Sky Bio or they want to go back to what they have in their own practices.
What are your thoughts, Cory?
Yeah, I mean, obviously, with being with Blue Sky Bio and sponsoring this course, that is a big part. I think our implants are great. I don't think anyone else is integrate. No, I'm just kidding. But we do want them to experience our products. We think we've got a ton to offer. But the biggest driver behind this course is the guided surgery aspect. And so I know for a fact, everyone's got pretty good implants for the most part. No one can touch us as far as the digital. The guided surgery and being able to do it affordably, that to me is the biggest thing that Blue Sky Bio can offer. And that's what we want them exposed to and to appreciate. And then I think if you get that, the implant stuff logically follows after that. And going back to how you started this whole thing about, you've got insurance driving costs down, you've got patients in a lot of areas that can't afford really expensive treatment. If you're starting off with a $400 to $600 implant, and then the abutment's going to be another $300, and then you're going to send off for a $400 crown, there's nothing left at the end of that with what you can actually charge in my neck of the woods. And so that's a big reason why I've used Blue Sky now for quite some time, even before they knew who I was or before I worked for them, was because their business model enables me to deliver a good, high-quality product at an affordable price, and I pass those savings along.
So we podcast interviewed the founder of Blue Sky Bio, Sheldon Lerner, DMD. Did I say his name right, Lerner? Lerner. Yeah, he was podcast number 89. I like that guy. Are you still working, or are you working with him closely on this?
Oh, yeah. I speak with Sheldon daily.
Daily? Well, tell him I said hi. He was podcast number 89, and now we're at 950. Tell him he had to come back on the show, or better yet, tell him I want to podcast interview him live in Guatemala City.
Okay.
At your course. That would be the most fun.
That's very good.
And we'll do it really early in the morning before we start drinking. And yeah, I love Sheldon. I mean, I think he's a great guy and he's a great company. And by the way, FYI, these are never commercials. No one's ever paid me a dime to be on my show. I don't get a dime for bringing these guys on. This is just I just talk to people. I just like to find townies that are passionate. So I got another question for this little girl that just come out of school. She's 25. She's $250,000 in debt. She says, I didn't place an implant. I didn't do any ortho. I didn't do any Invisalign. I didn't do any sleep apnea. And she's overwhelmed about all these things. She sees all these courses, the Pank Institute, the Scottsdale Center, the Spear, Coy's, Ross Nash, all this stuff like that. But don't forget, she's got her eye on $250,000 of student loans. Do you think implants are a great return on investment? And if your daughter just walked out of school $250,000 in debt and is going to open up in Winchester, Tennessee, what would you tell her? What new skills out of dental school would you tell her to learn so that she can pay off $250,000 of student loan debt?
Okay, so I was one of those people coming out with that much debt, and obviously, it's gone pretty well. Implants in my practice started a little slow, and then every single year, we nearly doubled every single year until we were replacing over 100. So for me, I think it's a no-brainer. What's the absolute first thing you should do out of school? I think that's always your root canals, your extractions, your bread and butter. It always cracks me up, and I say this in my courses, that dentists come out and the first thing that they want to do is go pay $60,000 to Frank Spear or John Coyce and learn full mouth rehab when they're going to do one full mouth rehab 4 years from now, and that's probably the last one that they're ever going to do. Those are amazing courses, and they're awesome, and there's a time in your career when that's probably excellent, but that's not going to be your day-to-day. That's not going to be what pays the bills. Your root canals, your extractions, your dentures. Why would you go learn full mouth rehab when you can do the ultimate full mouth rehab in dentures all day long, every day? Everyone else is referring them out. Get efficient at that, and then everything else in dentistry builds on dentures. And then the implants is a big part of that as well. Patients have missing teeth. They don't want a partial. So how are you going to help them with that? Are you going to send them off to the specialist, who will probably charge them 3 times what you could do it for? It just doesn't make sense to me. So, implants is a big journey. You can certainly get in over your head very quickly, but placing a routine implant is not rocket science. I mean, most dentists can learn to do this. And the research we've done shows that if a dentist is competent and comfortable in doing a surgical extraction, then they will press through and do dental implants. Because you see a lot of these people, they go to the course, then they never place one. It's kind of how I did with ortho. The difference is if that doctor is someone who will do a surgical extraction and is not afraid to remove a little bone, they'll do implants too. And it's not going to be a problem.
Yeah, and a lot of them, so many of my meet, they say to me like, well, I don't really like molar endo. Well, I don't give a shit if you like it or not, man. You decide to be a dentist, you're $250,000 in debt. Suck it up, buttercup. I don't want to hear your snowflake bullshit that you don't like molar endo. And you know why you don't like molar endo? Because you're horrible at it. After you do 100 molar endos and get good at it, it actually turns fun. So much of life is an attitude. And back to your denture deal, I still think that the people who took implants the farthest did it with dentures and a bait and switch. And same thing with an extraction and a bait and switch. What's that large denture clinic that is affordable dentures, has like 100 locations? You know what they do? They go into every market and they find what every general dentist charges for a single tooth extraction, and they go $20 under the lowest, and all they advertise is like an $89 extraction. Well, who the hell comes into your office needing an $89 extraction and doesn't have a world of work to do? So they pull that $89 extraction, but they get a chance to present to you, a ton of dentistry. And same thing with dentures. The guys I know that just blew it out of the water, same thing. They'll do a bait and switch denture. They'll get good at dentures, and they'll have the lowest cost denture. But when you come in there, they'll have the low cost denture, maybe full mouth $450, and then nicer teeth from Ivoclar maybe $650, and then the nicest one maybe $1,000. and then a denture on 2 implants for 5,000, a denture on 4. So they advertise that low cost implant or low cost denture. And I know people that when I got my fellowship diplomat in the International Congress of Implantology, a couple of my classmates went and bought a denture clinic that wasn't even owned by a dentist. It was owned by a denturist, and they were doing like $300,000 a year. And everybody in the county knew Denture World was the place to go. And then he took that place from doing $300,000 a year to $3 million a year because they could convert some of these to denture on 2, denture on 4, or all on 4.
Yeah, absolutely. I mean, that's your denture patients are primed and ready. I mean, you never talk to a denture patient that's happy with their situation. So, yeah, you've got a patient that's primed and ready for implants right there. So I think young dentists are insane if they're sending dentures out the door. They ought to be doing every one of them that they can, if for nothing else, just for practice, because you learn so much about where teeth go in the mouth and vertical dimension. All these full mouth rehab things you were going to spend $60,000 on, you can learn in your practice, and maybe Delta will pay you $14 for that denture. And then you've got a patient that's primed and ready for actually getting implants. And so, OMI does this all day long at their program, and this is a big part of what we're trying to teach dentists to do down at at the DISS course, is to be able to take those patients from either missing tooth here and there or just full mouth edentalism, and to be able to stabilize their dentures or to replace that missing tooth. It can really change a patient's life.
So your website is dentalimplantssurgicalseminar.com. Omid, what are my homies going to find if they go to, could you get dis.com? Did you try to get diss.com?
I tried. That was taken, unfortunately. And the reality is I wanted to go with the name that you could actually say the name and recognize exactly what it is. I want to tell you what it is without you even looking at the website to get a clear version of what we're trying to do. So it's about implants, it's about surgery, it's a seminar that you place an implant, and so on and so forth. So
what are they going to find if they go to dentalimplantssurgicalseminar.com?
So basically what we are trying to go ahead and give them, we tell them benefit of what we do, what we give them as far as, when they come to our course, what they should expect to learn, the university. We have to get them a temporary license.
That is an adorable photo of you, by the way. I have to admit, I love that. You do. You look literally GQ, buddy. You could be on the cover of GQ wearing your DIS hat. That was a cool picture. But anyway, continue.
Thank you. So basically, it's what we offer them, what they're going to get, and for our course, they're going to get everything. Basically, the minute they land in Guatemala, transportation, hotel, food, accommodation, university, their tuition at the university, their temporary license, everything is basically covered from the time that they are landing there. The only thing that we do not provide is for them to be able to go ahead and get themselves there. And the ticket is not part of this program. So once you have your ticket and you sign up for our course, everything else is we take care of. And, we're going to teach you how to place. And this is an investment. I mean, just like anything else, education is an investment. I agree with Cory. If you have $250,000, debt, this might be a little bit hefty for you. But certainly, I can't imagine that there is any other course, as far as the price is concerned, to be anything close to what we have. I think the other competitors of ours are, good 4,000 to 5,000 higher than what we charge. But it's just like everything else. Education is an investment, and this is a discipline that we're going to teach them that they normally would not, and be able to make money with it.
And by the way, I just retweeted you. You're at Dr. Termechi, Termechi. I just retweeted you to my 23,000 followers. Thank you so much for following me at Howard Farran. So let's go some of the basics that's in our mind. What do you say are the most controversies in implant dentistry, and how you can address that? That concerns a lot. They want to know the biggest concern these associates are telling me is that they went into an older guy and he did this. He learned how to place implants, and now 5 years later, 20% of them have Peri Implantitis. What do you agree? And you teach implants and perio. Do you agree with that number that in 60 months, 20% of implants have Peri Implantitis? And what is that? How do you wrap your amazing mind around that, Omid?
So I don't know where you get your stats from. I mean, I don't know where that's really coming from. I don't know if we had that much Peri Implantitis coming through, it would be a very, very terrible discipline, this implant dentistry. We certainly do have our big share of Peri Implantitis as the implants are being placed more and more each year in the United States. So we see all the old ones that are coming through. I actually posted a case on Dental Town this morning, or actually maybe possibly last night. I posted that one. My first case that I actually posted on Dental Town was last night, and that was the topic. The topic was to try to avoid, and most people don't recognize, to try to avoid as much as possible peri-implantitis in the long run. Peri-implantitis sets in the long run. It's not a quick problem that we see. It's a long process that's going to come about in the future. Now, one of the things that I do is, and one of the things that, Cory teaches as well, is we got to make sure that we have good sound amount of bone around our implants. A lot of times when people who kind of just want to place an implant and don't have any other education beyond that, they place the implant in a very thin buccal area. And as the tooth goes into function of many years of being in function, and if that bone, with all the pressure that's exerted on it, it starts going away, then bacteria sets in and it zips right through on the buccal. And most of the time we see it on the buccal area. We don't see it on the lingual. Why? Because you just have more cortical bone on the lingual side and much thicker bone on the lingual side. So therefore you don't see it on the lingual. You see it on the buccal. So one of the things that we want to teach our participants is the fact that recognize these patients are possibly maybe not for you to tackle at the very beginning, but try to go ahead and get a little bit more comfortable. And then there is a bone graft courses that you could go ahead and take and more education to be able to go ahead and do it. So most of the time, even if my implants are not exposed as far as the thread is concerned, if I see there is a thin amount of bone that's covering my buccal side of my implants, I opt for a bone graft. And I suggest that everybody does, only because in the future you would have problem with that.
Well, you asked where I get my data from, and I've podcasted 1,000 people like you, and so I just went to perio.org. That's the American Academy of Periodontal Studies, and they said at 9 years, 36.6% of implants have peri-implantitis at 9 years, and I've seen several studies that at 5 years it's 20%. So it is significant. It's also the people that get implants, they're usually not your vegan yoga instructor. You know what I mean? They also seem to have a lot of habits. I mean, how did you end up losing all your teeth? Well, I was smoking, drinking, eating craft dinner, forgot to join the gym. You know what I mean? So a lot of times I see that with All on 4 where, they were disaster mouths. And then they go get all that done. Then they come to your office and they've got half a loaf of bread underneath their fix. So patients are patient selection. So you guys cement or screw? A lot of people think the cement has something to do with peri-implantitis. You guys cementers or screwers?
You go ahead.
Cory, you want to answer that before I get into it?
So I am actually one of the few that's on the cement bandwagon. But with that said, I want it on a custom abutment, and I want that abutment to be a 0.5 millimeter subgingival on the facial and everywhere else, like interproximal, equicrestal, or equigingival, and on the lingual, I want it supragingival. Because cement, when you put that on, as long as you're not putting a massive amount and filling the crown up, it's going to flow out of the path of least resistance, which in the case of how I design them is going to be on the lingual where it's supragingival. And to me, those are just 10 times easier to deliver. I'm not worried about 2 paths of draw. With screw retained, you've got the path of draw with the screw and the implant, plus the path of draw of the restoration with the contacts. And I just think they're far harder to deliver. So I am preferring cement retained, but on custom abutments. I don't know. What do you think, Omid?
I remember when I was in my, implant residency back at the beginning of 2000, everything was being screw retained back in the 90s. And then it comes, to the 2000s, beginning of 2000s, everybody says, it's more aesthetically pleasing to go ahead and do cementable. Why? Because I don't see the chimney running right into the, in the middle of the implant. Sometimes you really can't do it because the position of the implants, the way it's positioned. And now today, again, we're going back to that whole process of doing the screw retain. Certainly, both of them have their advantages and disadvantages. I mean, I had my share of fracture screws, where patient functions on the screw. So, that's your screw retain issue. And maybe you can get it out, maybe you cannot. And then obviously Peri Implantitis and cement that you were just discussing that, we have a lot of that problem. So personally, in my own practice, I pick and choose based on a particular case, whether I think it's a cementable or a screw retain. And it really becomes a clinician judgment call to figure out, if I do it this way or the other direction, which one advantageous to the patient. If they both equal out, then I consider aesthetic of it and see, whether I want to go ahead and put the, screw in the middle or not. So to answer your question, I'm 50-50. I believe that the cementable definitely still has a place in the implant dentistry. A lot of my colleagues don't even go close to it anymore. That's it. They do everything. They do somersault to go ahead and try to get the screw retain, on their implants. But I don't necessarily do that. I still use cementable, and occasionally I posted my second case or the third case on Dental Town today, and it's anterior aesthetic zone, and that one is a screw retain. And I like to actually, when it comes to aesthetic zone, I like to go ahead and go more on the screw retain. I have more ability to manage the soft tissue and the zenith of the maxilla.
But I want to tell you kids one thing. You stay out of that aesthetic zone for the first 100. Don't even get near there. Your starter cases, your starter cases are something. I mean, when because it seems so easy because it's right there, it's in front, you can see it. Oh my God! One of the first implants I did was number 8 on a gorgeous girl, and thank God I had a prosthodontist, implantologist that I had to go give several $1,000s to redo the whole thing. So start in the back. I want to ask you another question. 30 years ago, when I got out of school, implant success was how long you could get in there. And I mean, oral surgeons were doing mandibular nerve, moving mandibular nerves to get them extra long. But it seems like the trend is that implants are actually getting shorter and fatter. Where are you at in implant success being long? Who's the guy on Dental Town from London that always places these short, fat? Bill Schaefer. I mean, that guy, and a guy like me wants to always promote short and fat. I mean, is there anything I hate? It's tall, dark, and handsome and skinny. But so where are you at on the evolutionary scale between a tall, dark, and handsome implant versus a short, fat one, so you don't have to worry so much about the inferior alveolar nerve and sinuses?
So I don't. There was a literature that came out in I believe is the Perio, that if you have to sacrifice one of the other, which one would it be? Thickness versus length. What would you sacrifice if you could go ahead and sacrifice one? And everybody agrees that you sacrifice length for width. So width of the implant definitely is a major aspect of the implant that gives you a great success in the long run. The only problem, again, it comes about if whether you have bone or not. I don't believe that you need to go anything beyond 10 millimeter in order for you to go ahead and accomplish. I know I myself, I place a 13, an 11 and a half, when I can, and I see the bone there. But here is the problem, Howard. I think one of the big issues is what you just mentioned before is a Peri Implantitis today. And can you imagine having an implant that's 13 or 16 millimeter long, and now that implant is suffering with Peri Implantitis, and that implant is in number 7 area between your lateral incisor and a canine, and now you as a surgeon want to go ahead and remedy that problem. that becomes a huge, huge problem for any surgeon to try to tackle. If the implant has Peri Implantitis, that does not necessarily mean that the implant is loose and it's ready to come out. That means you really need to go after it and get it out, and then try to recoup the area with the bone and whatnot, and just either repeat the process or go conventional dentistry. So I don't believe going longer is necessarily better. I think as long as you have a minimum of 10 millimeter on your implant, you're in good shape. Okay, 4 by 10 is a standard all around. You could put it in the posterior maxilla, you could put it in the anterior mandible. It all works, and it's good size implant for you to be able to place. In the past, we used to go ahead and consider putting bigger implant in an aesthetic zone and in immediate cases where you took out a central incisor, and now you're putting a 5 or 6 millimeter implant in the central incisor area. Today, we say, no, you don't need to go that big. You could go put a regular 4 and try to preserve more bone in the buccal area, so you have a thicker bone with a narrower implant is a better process rather than a thicker implant with thinner bone in the buccal area.
I want to ask you this question. If you had you're in New York City area, you're in Long Island. What if Lady Gaga came in your office and she was missing number 8? Would you? There's a lot of people, myself included, that think that if aesthetics is your top priority, a 3-unit bridge is probably more aesthetic than a single implant crown on the 4 maxillary incisors on a beautiful woman with a high lip line. Do you agree with that or disagree with that? What would you do on Lady Gaga if she's missing number 8? 3-unit bridge, single implant.
That's a very broad question. A very, very broad question, only because you have to also consider the situation or the circumstances that patient presents itself. If I go ahead and I take a look at Lady Gaga and I look at the literature and I see that she fits under the diagnosis of the literature, that I can go ahead, and if you have the experience of it and you repeat this process over and over again, and you know that you could go ahead and do it, then if I can try to get the aesthetic result that I get normally with an implant, I will certainly go ahead. I posted this case where a 46-year-old male came into the office with an accident, and tooth number 8 popped out, and soft tissue is missing, the bone is missing, and if you take a look at the very end, the last slide where it shows that the tooth is in his mouth, you can certainly see that the aesthetic is well preserved. Now, I do agree with you that a lot of time you got to just say implant is not the answer here. And you got to just go back to the conventional dentistry with the crown and bridge, and you probably get a better result. I do agree with you. There are cases that it's probably best for the patient to go with a 3-unit bridge or 6-unit bridge, whatever the case may be, as opposed to going ahead and trying to accomplish that through implants. Yeah.
Same question to you, Cory, but since you're in Winchester, Tennessee, instead of Lady Gaga, it'd have to be Dolly Parton. If Dolly Parton came in your office from Operaland, USA, what would you do? What was number 8? Would you implant, single crown, or 3-unit bridge?
I would say, sorry, I've retired from clinical dentistry. I would pass the buck. Let's assume there's plenty of bone there. With plenty of bone, I would do the implant. If the patient's going to have, soft tissue grafting and add bone volume and multiple procedures, and let's say that both adjacent teeth have, MIFL composites on them, heck, I'm going to do the bridge at that point. Again, it is case dependent, and it all goes back to the bone. And circling back to what Omid was saying earlier, this stumped me for the first 6 years of my career, is that I would place this implant and I would get this great primary stability, and I would come back, I would bury it completely, come back, there's no exposure of the cover screw, and I take an x-ray, and where it had been a millimeter under the bone, now there's bone loss down to the first thread, and it's not even been exposed to the mouth anymore. And what I finally realized, and a lot of this came from a lecture that Dr. Lerner gave in his sinus series, was, you're placing it into this sharp ridge. You've got a tapered implant. The highest pressure is up here at the crest where the bone is the skinniest. And so you're putting in green stick fractures. You're right against these cortical plates. There's very little residual bone around this. And I don't care if you do bury it, that bone is going to melt away. And so I would, in that case, go with a skinnier implant to try and preserve some actual native bone around that implant. For most dentists, I would say the safe bet is going to be, in Dolly's case, to do the 3-unit bridge, because you're talking about some serious skills if you've got to be able to regenerate hard and soft tissue. If it's plenty of bone, plenty of tissue, and you've had enough experience in implants, I would go for the implant.
I want to just jump in for 1 second here. DISS is definitely for beginners. Our goal is really to go ahead and get their hands wet and let them place 15 implants or so in our program and learn implant dentistry, understand bone, feel the bone. Our participants who have already signed up, they're averaging somewhere between none to 30 implants in their career so far. And one of my participants said to me, he says, I have placed implants in my practice. My son and my son-in-law are dentists, and they place implants. But every time I get a implant case that's coming in, I start sweating from the day before. So that's our goal really is to make them comfortable. We want them to be comfortable and recognized, but no aesthetic involvement of any sort. Later on in the future, once they get more comfortable and they educate themselves, then they can try to tackle that. But I would definitely not suggest that for them at the beginning.
Okay.
Let me tell you one other thing, Howard. One of the things that we're doing that I don't know of anyone else doing this, but I think it's going to be a big benefit to the attendees, is with all the 3D printers and everything that I've got, and the fact that we're doing it guided means that we have a cone beam on these patients ahead of time. So one of the unique things that we're doing is we're actually going to 3D print that actual patient's jawbone out, and they're going to get to do a mock run at the surgery. So let's say your first case in the morning, that it's your first ever implant. The day before or that morning of, you're actually going to have that patient's jaw, and you're going to do the mock surgery on their jaw and be able to anticipate potential complications, and just you get a dry run at it. It's really beneficial rather than just some stock practice model. And so that's one of the things we'll be doing for all of these patients.
Okay, another big question they have is, one stage or 2-stage surgeries. There's a lot of patients, the tail's wagging the dog. They want the immediate loaded. They want to walk in, get the implant, walk out with a tooth. What do you think about 1-stage versus 2-stage and immediate loading? And does your course go into that?
So we're definitely going to discuss doing the 1-stage versus 2-stage as far as the implant is concerned. Certainly, the days of Mark where he came in, placed the machine type implants, and it was a 2-stage type of implant, and put it on the soft tissue for 6 months and come back and recover and then start a restoration. Those days are kind of over, and that's partially thanks to the surfaces of the implants today, that, we are just more technologically advanced as far as the implant surface is concerned. So we have great surfaces that, all implant companies have good surface, and that's definitely great benefits, and the integration is much, much faster. So we definitely going to touch upon where to go ahead and do it 1-stage versus 2-stage. As far as the immediate load is concerned, our program is not going to touch upon that because that's a little bit more advanced. We are, whether it's aesthetic area, whether it's a full mouth kind of reconstruction, that's kind of falls into the more advanced cases. But to answer your question, it's a very mixed attitude in the world of dental implantology today. If you have a patient that comes to your practice and aesthetic zone is an issue, and a patient, let's say you see a patient mid-40s, a lawyer that goes in front of the judge, and or a businessman and whatnot, these people don't want to walk around with teeth that pops in and out. So maybe 5 to 6 years ago, we were doing all these immediate cases, one after another. although the literature does show that immediate cases are almost as successful as a regular implant, conventional implant placement. And I say this because the clinician is very selective of who they pick. It's not because immediate, it's an easier procedure, or immediate, we're not putting implant more in jeopardy by doing it. But we are very selective of who we pick. A lot of times, whether the implant is in there and it's well, fixed into the bone, whether, you get a good amount of torque on the implant, whether the patient is not a smoker and a healthy patient. So we pick and choose when it comes down to immediate cases. But when it comes down to regular implant, everybody falls into the category of, okay, we're going to place an implant and we deal with it, whatever happens. So immediate cases are very successful, but I definitely do not recommend it for beginners to go ahead and do that, especially in aesthetic zone, because that's just very, very tricky. You just got to know a lot of different, the placements, the soft tissue and whatnot, and that just takes, a few more years.
Yeah, and no doubt. And the family tree's a great place. That first dozen implants I placed was all on. I needed some free volunteer research monkeys, so I just started calling all my family, and they, that was great. And another thing that's always on their mind, a lot of thing they're asking is platelet-rich fibrin a PRF? Is that something you need in your armamentarium for your average bread and butter implant, or the use of sticky bone? Is that do you think that's overkill, or is that necessary armamentarium for your average implant general dentist placing? And by the way, you have to place 50 a year. I can tell you, I'm a dentist and an MBA, and I love dentistry, and I love the business of dentistry, and I have never seen anybody in the profit zone doing any procedure less than one time a week. When you're doing an implant once a month, a denture once a month, a root canal once a month, you're so damn slow. You're so damn slow, you're not in the profit zone. So if you're going to set out on implantology or Invisalign or sleep apnea or anything, I mean, look at sleep apnea. You could drop 30 grand just trying to learn sleep apnea. And then what? You go back and do one case every quarter? Would you want to go to a doctor and be treated for sleep apnea who did 4 cases a year? So the critical zone is once a week. So back to that dentist who's going to set out on the implant journey, and they got to get to critical mass, the tipping point, profitability, the profit zone, 1 implant a week. Is the use of platelet PRF, drawing blood, spinning blood, making sticky bone, is that part of the protocol?
So it's certainly not part of our protocol, only because I do agree with you. When you are at the beginning of your implant journey, I don't think that that's something you need in your practice right now. When you start getting more active and you're placing more implants, then it becomes a little bit more. And that's really comes into, we're going to teach, Cory and I are going to teach a bread and butter type of implant dentistry where not too much bone needs to go ahead and get enhanced, and not too much of soft tissue involvement and whatnot. We really want to focus on a basic of implant dentistry. But to answer your question, I will just throw this at you right now. To answer you, I'm going to give you a statement, and your listeners can decide whether they will fall into this category or not. In order for you to justify PRF, you have to do much bigger surgeries where PRF comes handy as far as your bone enhancement and the soft tissue healing. So if you're placing 2 or 3 implants where you do not have to enhance any bone and you're not making tremendous amount of reflection of the soft tissue, therefore that PRF is not going to be too handy to you, and there's no use really for it. Because PRF, when I use it, is when I want to add a little bit more kick to my bone graft, and I wanted to go ahead and create the membrane that I need to separate the soft tissue, plus bruising, swelling, and whatnot. And those go onto the category of a much larger surgery, like a sinus graft. But if you're doing bread and butter, 2-3 implants, overdenture implants, things like that, where simple. And again, with the computer-guided surgery, we are trying to teach them to be less invasive rather than more invasive. And if you are going to stay like that, then you really don't, at this point, need a PRF system in your practice, and you don't need to invest on that just yet.
My God, I can't believe we already went 7 minutes past the hour. Holy moly, we're at hour 7. They're sitting in the parking lot saying, I'm at work. Will you guys shut up so I can go inside and see my patients? We do the show an hour because that is what their average commute is. And I want to thank you guys so much for coming on a Sunday afternoon in the middle of the Tennessee Titans and the Arizona Cardinals. This is how much we love dentistry. We just sacrificed the NFL for dentistry. But I just want one final question. Do you really think they need to learn how to place implants when it's right here on the news that Chinese robot dentist is first to place implant in patient's mouth? They literally placed an implant with a robot in China. So why should the dentist learn how to place an implant when they can buy a damn robot from China to place that implant? Did you guys see that?
So I want to tell you, by the way, I did not see this, but a friend of mine who went to the Greater New York Dental Meeting, he said that there is a robot now that basically what it does is, and Cory, you may find this very interesting, that you basically, after you take the scan, you plan the case, and you hold the handle and you bring it to the patient's mouth, and you doing the movement of the robot, but if you are diverting from your plan on the CAT scan, it would put some resistance and it will hold you back. So therefore, that, you could go ahead and go somewhere else, but the robot will kind of give you a little resistance, and you kind of have to stop. So, but you're right, Howard. Who knows? Maybe the robots will be placing implants soon, and we may not have to go ahead and do this.
Yeah, that's why I'm not going to get married again until it is a robot. So I'm waiting for the robot that places implants and can be my my next wife. And I just emailed you that article. I had Cory's email. I didn't have yours, Omid. So I just emailed to Cory. Cory, can you forward that to Omid so he can see that Chinese robot?
Thank you.
Yeah, I'm going to go to China to see if I can get a implantologist robot wife. How's that sound, Ryan? Hey, thank you so much for spending an hour on a Sunday with me. Love your passion.
Sure.
Love what you guys do for dentistry. Thank you so much for coming on the show today.
Appreciate you, man.
My pleasure.